amazing conference, which is one of its kind, hosted at the heart of India, Delhi, which is the cultural and political capital of our great nation, India. For the next session, I would like to invite Dr. Anita Jagetia, Professor GB Pant Hospital, Dr. Girish Rajpal, Associate Director, Max Super Specialty Hospital, Vaishali, and Dr. Shantanu Kumar Bora, Assistant Professor, AIMS, Delhi, on stage to chair the next scientific session.
Yeah. Good afternoon, all. So, without wasting time, we'll start the next this session. And Dr. Karapurkar is the first speaker. Huh? This is video presentation, recorded. Yeah, can we have his presentation on dural AV fistula, endovascular treatment of AV fistulas?
At the outset, I must thank the management committee for inviting me to give a talk on the endovascular management of intracranial dural AV fistula and AVM. I'm an endovascular neurosurgeon. Dr. Rakesh Singh is my colleague who's a neurologist, and Mrs. Sugandha Karburkar is our anesthetist. And we've been working at the Bombay Hospital. The etiology of dural AV fistula is in India because venous sinus thrombosis is common, often secondary to venous sinus thrombosis. It can be secondary to trauma, it can be secondary to infection. Rarely it is congenital, and in 8% of patients there can be multiple. The problem is it is often difficult to diagnose and often not seen even on a good quality CT, CTA, MRI or MRA. So the DSA is a gold standard, and a DSA has to be a proper DSA study. There are various classifications, and the very fact that there are so many means that none of them is satisfactory. What we have to remember is what are the dangerous features of dural AV fistula. Venous congestion and hypertension causing raised intracranial pressure is a very common presentation. Intracranial hemorrhage can occur if there is a cortical venous reflux, and it becomes higher if there is a venous varix or aneurysm on the draining vein. So we have to basically look at the venous dangerous features, and these merit treatment. Raised intracranial pressure patients may present with headache, vomiting, diminished vision, convulsions. There can be confusion, lethargy or giddiness, and even dementia. And the hemorrhage, we have many patients who have been treated with oral anticoagulants or low molecular heparin for intracranial venous thrombosis, and they come back months or even years later with raised ICP, and these are due to raised due to dural AV fistula in place of the thrombosed sinus. The hemorrhage can be intracerebral, it can be subarachnoid, it can be intraventricular, subdural or extradural. And tinnitus on the side of the fistula, synchronous with the pulse, can be very annoying. Rarely, as I said, it is congenital. So this is a patient who had cortical venous sinus hemorrhagic infarct due to cortical venous sinus thrombosis, which is also well seen on the DSA. And this patient came back some months later with papilledema and a high flow dural AV fistula of the transverse sigmoid junction, as you can see here. This patient has bilateral dural AV fistula with venous outflow occlusion, and you can see the very severe venous congestion. So you can understand how there can be raised intracranial pressure because of venous congestion. This is a pure subarachnoid hemorrhage, and usually this is because of venous outflow into a cortical vein. This is a subdural plus an intracerebral hematoma, again in a patient who has a venous varix on a draining vein, and a pure intracerebral hematoma in a patient who still has a large venous varix. So venous varix is dangerous. If you see venous varix, treat these patients urgently. Patient who had what looked like a pure fourth ventricular hemorrhage with some reflux into the lateral ventricles, and following the EVD, this hematoma in fact enlarged. The patient became unconscious and decerebrate, and this is again because of cortical venous reflux and a small aneurysm on the draining vein. A dural AV fistula of the cribriform plate usually is associated with a large venous varix, and most of these patients present with intracerebral hemorrhage, and sometimes this can be a massive clot in the brain. So as I said, DSA is the gold standard, and bilateral internal carotid, bilateral external carotid, bilateral vertebral, and sometimes even bilateral subclavian angiograms are necessary. Arterial feeders are often multiple and often bilateral. In long-standing dural AVF, virtually every artery going towards the head is annexed to supply the AVF. And what is important is to identify the precise site of the fistula. Sometimes it can be very difficult, even for experienced people, to know where is the exact site of the fistula. So, where the draining vein starts, that is the site of the fistula. The artery is smaller, more tortuous, the vein is larger, more straight. So, if one finds a change in the caliber, that is the site of the fistula. And one should try and find the primary venous outflow, because like for a spinal dural AV fistula, all that one needs to do then is to just coagulate and burn the draining vein. So this is just to show the venous outflow. This is a antegrade venous outflow, usually needs no treatment. The second slide shows massive reflux. The third slide shows, the third image shows reflux into a cortical vein, and the fourth also shows reflux into a cortical vein. So if there is venous reflux into a cortical vein, urgent treatment, as I said earlier. How do you treat them? Observation, surgery, embolization, or radiosurgery? I personally don't believe in radiosurgery, and surgery I think should be reserved for those which are where there is no arterial access for the endovascular route. So the endovascular route can be arterial, it can be venous, or it can be by direct puncture of the sinus. To show you some examples, this is a 3-year-old child who had a very large, very high flow fistula, where the bruit changed by pressing on different points behind the mastoid. And we reduced the flow by first embolizing through the arterial route, and then we went through the venous route. This was done in 99, more than 30 years ago, and she's been doing extremely well. And she's now a big shot, grown-up girl. This gentleman, globe-trotting engineer, had progressive loss of cognitive functions, became progressively bedridden, became quadriplegic. By the time he came to us, he was unconscious. You can see the severe venous congestion here. So in this patient also, again treated in 99, after reducing the flow through the AV fistula, we occluded the vein of Galen. Today probably we would not occlude the vein of Galen. We would go through one of the middle meningeal arteries and occlude the fistula through that. This was a patient who had an incarcerated sinus. There was no access to it from either side. So here we made a borehole directly on the affected sinus, and we packed the sinus with coils and glue to get a cure. What is the treatment of choice today? The treatment of choice today is to find an artery which will take us to the site of the fistula, and from the artery inject into the venous sinus or cortical vein, so that from there it will reflux into every feeder. The aim is to get every single feeder. And sometimes we add a balloon on the venous side to reduce the number of vials of onyx that we use, and also to keep the sinus patent. Especially when we are at the tocula, we have to keep the tocula open. So then we use the balloon on the venous side. Often 3 or 4 vials are required, but if one starts and the onyx is penetrating, one should continue until one has got the full fistula. So in one patient, for instance, we have used more than 40 vials. I think we have finally used more than 50 vials in that patient. So these are typical example, a high flow dural AV fistula with the venous outflow into the transverse sigmoid junction. We have injected with onyx, and you see the onyx cast. It's gone into the sinus, and from there it has reflux into virtually every feeder. You can see myriads of feeders there, and this is how the fistula gets closed. The patient with the subarachnoid hemorrhage and raised intracranial pressure, but also progressive ataxia, and you can see the cortical venous reflux. Again, we have injected onyx, and look at the way the onyx spreads from the venous side into the artery, and the effort is to try and get the entire venous sac and the arteries feeding the sac. This was a very unusual presentation of a CVJ AV fistula, which had caused raised spinal cord compression, raised ICP, raised pressure in the spinal cord with large vessels on the surface of the cord. You can see the cord, spindle-shaped cord edema. Patient had come with progressive quadriparesis and paraparesis, then quadriparesis, double incontinence. And this patient had a supply from the occipital artery and also from the vertebral artery. So this is the occipital artery and this is the vertebral artery feeder. So we, as far as possible, try to use a dural artery coming from a branch of the external carotid artery. So here we have gone through the occipital artery and we have placed a balloon in the vertebral artery to protect the vertebral artery, vertebro-basilar circulation, so that the onyx doesn't penetrate into the vertebro-basilar circulation. And you can see the onyx cast and the fact that it has got obliterated. A patient with a cribriform plate, AV fistula, this is a typical hematoma which is seen. And though the hematoma may be on one side, typically these patients present with hemorrhage and typically the supply is from both ophthalmic arteries and sometimes from both external carotids as well. So rather than go through the ophthalmic artery, we chose to go through the venous route here. We have come from below, we have gone through the transverse to the sigmoid to the superior sagittal sinus all the way, and the onyx cast, as you can see here, has to be complete to be able to get the fistula. Otherwise, the patients come back with a recurrence. So here you can see that we have closed it. This was a 30-year-old male, 39-year-old male who came with progressive loss of cognitive functions. He was drowsy, he had papilledema. And if you see his supply, it is from a leash of vessels coming from the internal carotid artery. And there are large venous varices along the course. So here, because the supply was not from the middle meningeal but from the occipital, we did this. In the occipital supply, we often use a septal balloon. This gives what Rene Chapeau has described as a pressure cooker technique, where we occlude the artery so that there is, inflate the balloon to occlude the artery, so that there is a greater penetration of the AV of the onyx and we get a complete obliteration. So we have used this septal balloon, especially when we have used the occipital artery as the source of embolization. This was a gentleman who had had a severe Rui tinnitus, thin corners with the pulse, didn't allow him to sleep at night. He had become a nervous wreck. And he had had a previous session of embolization which had failed. So when he came to us, he insisted that we try and treat him completely. And now there was no arterial access which was satisfactory. So we decided to go through the venous route. Again, we came from the transverse sinus to the sigmoid sinus. And we used a balloon to occlude the venous side this time. And through the same catheter which was occluding the venous side, we injected the onyx. So here we have used an eclipse balloon, and you can see the onyx penetrating to the venous side. And this is the cast of onyx that we got. And in fact, with a very little volume of onyx, we were able to cure this fistula. This was a patient in whom we had a complication. He is a 14-year-old boy, occipital fit since childhood, large D, very high flow AVM. We were waiting on him for about 3 years, but he started complaining of progressive headache and progressive worsening of vision. And you can see here the high flow, multiple fistulae, multiple feeders to this very high flow to AV fistula. There are cortical branches giving off dural arteries which are supplying the dural AV fistula. This is in long-standing AVM not uncommon. And you can see the very high flow fistula. There is occlusion of the left sigmoid sinus, so it's going across to the right side and to the superior sagittal sinus. So virtually every artery supplying the head was supplying the fistula. So here again, as I said earlier, you have to be very careful to see the site of the fistula. And here, this is the left vertebral angiogram, the left internal carotid, left external carotid. Virtually every artery to the head was supplying this fistula. And when we tried to first time go through using the onyx as usual, we found that the flow was where you can see the way the wire is flipping back and forth. And the onyx, the onyx, I mean the contrast would have just, the contrast just flew past. If we had injected onyx, it would have gone straight to the venous side and occluded gone to the lung. So there was no that we could do it that way, no way that we could do it that way. So we decided to use a balloon to slow the flow down. So here we have used the jugular vein as an axis. We have a catheter coming in on the arterial side from the groin, and we brought in two wires, one for the balloon, on which that is a balloon which has been inflated. Through the other we deployed coils. However, we first deployed the first coil but did not detach it. We added more coils, detached the second coil, left the first coil in place, deflated the balloon partially to see what would happen. The coils were remaining stable. So then we added onyx and we completed the embolization. This was a long procedure, but finally we got the whole fistula, and we were very happy that we had got it. Patient was very well. Next morning he woke up with severe headache and vomiting, and CT showed a hematoma in the occipital lobe. 4 hours later he worsened, so we had to take him up in emergency, do a craniotomy, evacuate the clot, and he did very well. And so when we treat a dural AV fistula, we always do an immediate scan to look for hemorrhage. We do elective ventilation for 24 to 48 hours. We give low molecular weight heparin for at least 5 days. And if there is no hemorrhage due to the hemorrhagic venous infarct or due to hemorrhage, we anticoagulate the patient by oral anticoagulation for at least 3 months. And we repeat the DSA after 6 months. Anticoagulants are continued for 2 years. So complications are hemorrhage due to partial obliteration of residual or due to residual venous outflow, progressive venous occlusion, and despite low molecular weight heparin, due to stagnation of blood in the dilated redundant veins, convulsions, or a recurrent fistula. So in conclusion, they are difficult to diagnose. A high index of suspicion is required. A careful analysis of the arterial and venous outflow is required. And surgery is only for cribriform plate dural AV fistula, which has no meningeal feeder. Or if there is a venous outflow into a single cortical vein, so that single cortical vein can be coagulated and divided like in a spinal dural AV fistula. Thank you for your attention.
Is he available online to take the questions? Huh? Hey? Thank you, sir, for a wonderful talk. And as usual, we always learn a lot. It's open. Talk is open for discussion or comments. He's available online, huh?
Yeah, I'm
So you are there.
available,
Hello,
and
sir.
if there are any questions, I'll certainly try to answer them.
Mute, hai? So you are mute, I think.
No, I've unmuted
Yeah.
myself from here. I don't know about the organizers.
Yeah, nice, very nice talk, sir. As usual, every time we learn a lot. But I just want to ask one thing, sir. You said septal balloon to take for the occipital feeder. So many a times you are unable to reach to the occipital distally right up to the venous side. So is there any trick to reach to that place, because the artery is so tortuous and
That is the whole
sometimes?
problem, because many of these are transosseous connections.
Yeah.
And to get through the transosseous connections is very difficult. So we are always removed from the site of the fistula. That is why we add the septal balloon.
Okay.
The septal balloon occludes the artery, prevents a reflux, and there is good penetration. So whenever we are using the occipital artery, almost always we use a septal balloon. Septor or onyx or eclipse you can use. You have to use a balloon catheter which is onyx compatible.
Okay.
Yeah. So we use that.
Excuse me, sir. Sir, in
Yes.
a case you have shown a balloon simultaneously along with two coils and onyx.
Yeah. Correct.
May I know which hardware you used to take these four systems simultaneously?
So we had, as I showed you, we had one venous route, one big venous catheter, that's the Neuron Max. The Neuron Max can go up very easily. It has an ID of 88. And through that we can take two catheters. There is no guiding catheter there. It is just the Neuron Max. And then through that we have taken the micro catheters. So we have taken two micro catheters, and we have taken so we've taken coils inside. So the trick here is, because it was a very high flow, we did not detach the first coil. We left the first coil to provide a scaffold for the other coils. And we brought in, so there were two micro catheters. I don't remember which ones, but either Echelon or SL10 for the coil and for the balloon that we used. In fact, this was a very poor patient. So we had used a coronary balloon, a peripheral balloon, which is much cheaper than the neuro balloons. The neuron balloon, the Medtronic balloon is very expensive. The Bolt balloon is very expensive. So we have used a peripheral balloon, which is more stiff. That is the reason why we also took the Neuron Max all the way into the transverse sinus. So it was a coronary, no, it was a peripheral balloon actually, not a coronary balloon. It was a peripheral balloon. And it was a 10 mm diameter. You have to have a large, the transverse and sigmoid sinuses are large sinuses. So we need a 10 mm balloon. So the balloon was a 10 mm peripheral balloon. And the coils were the standard coils, the largest coils, 24 mm by I think 50 or whatever. Nanonics.
Okay, sir. Thank you.
I don't believe in using the pressure cooker technique every time. A lot of people use it every time. We just use it for the occipital artery basically. At all other places we just use the marathon, which is much cheaper. And you can allow a reflux in the marathon. Usually we are in the meningeal. So we can allow a reflux all the way up to the foramen spinosum. Don't let the onyx come below the foramen spinosum. The other thing that I always tell my boys to look at, so it's not only me who's looking at the screen, but my boys are also looking at the screen, the technician, the assistants, our residents. When it is refluxing into the artery, sometimes it can reflux into anastomosis like the tentorial artery. It can go into the internal carotid. Or between the occipital artery and the vertebral artery, it can go into the vertebral artery. So you have to imagine where the anatomy would be, where the branch would be, and make sure that you do not exceed the length that is permitted. Like for a tentorial artery, don't go beyond the mastoid, in the artery. So you have to be very careful about that.
Thank you, sir, for your inspiring and enlightening talk on AV fistula. If there is no further question, we can proceed to the next talk.
Thank you.
Now I request Dr. Anita Jagatia ma'am to present her talk, Concepts in the Management of Cavernous Fistula.
Pointer. Okay. Yeah. Good afternoon all, and thanks to the organizers for this wonderful meeting and accepting my talk. So this is about carotid cavernous fistula. Over the years, we have learned the concepts and how to manage, and this includes not only the treatment part. It includes the understanding the anatomy, which is very important, as Dr. Karapurkar also pointed out in his talk, that you need to understand the anatomy, visualize the anatomy, imagine the anatomy. All those things are required. And I would like to say that endovascular is not minimally invasive as is perceived. It is as invasive as any procedure, because you are hitting the system right from the groin to the brain. So at least 3 or 4 feet you are traveling. So it cannot be minimally invasive. That is one thing. So we all know that Barrow's classification. Just to summarize, this is type A fistula. Here is internal carotid artery. This is cavernous sinus. These are the branches of the internal carotid artery, which can be from the anterior aspect, posterior aspect, or the anterior aspect. So this is one where the main artery, the big, huge artery, is communicating with the cavernous sinus. This is B, where a branch arising that is communicating with the sinus. In C, this is a branch of external, which is communicating with the sinus. And in type D, both the branches of external and internal are communicating. So what all things one should know when we are planning to manage the CCF, the type of cavernous sinus and its venous drainage, the location of communication, then which route you will take to close based upon the type of this cavernous sinus, drainage or the communication, and what material you are going to use. So this is a CT angiogram where we see that these two are the cavernous sinus, and we always think that the cavernous sinus is this huge cavernous sinus, what we read in anatomy. But if you see these angiograms, here you see there are trabeculations in the sinus. You see all around the artery, but this is trabeculated. Here you are not seeing all around the artery. It is only the anterior part which is filling up. Here you are seeing the artery. This is too bright. Here you are seeing this sinus, and again it is trabeculated, but it is less trabeculated. But if you see, there's so many veins draining out this sinus. Sinus is not so huge, but the veins are many: inferior, superior ophthalmic, cortical, then petrosal. And here the sinus is again not very huge. It is like any saccular dilatation, and the drainage is, and with this the drainage is anterior as well as posterior, with some cortical reflux. Here you are seeing only very slit kind of sinus, not a huge sinus. Then this you see, this sinus is again trabeculated, which has got so huge draining vein, and which is draining into angular and right up to the facial vein. Here the sinus, ipsilateral cavernous sinus, is rudimentary, but the intercavernous sinus is so prominent that it is filling up the opposite side of the cavernous sinus. Here the intercavernous sinus is patent, the ipsilateral is as big as any aneurysm, and the opposite side is so well trabeculated seen. So these are the different variations which you find in the cavernous sinus anatomy. And 18% of cavernous sinus, they have densely formed trabeculations, whereas similar percentage as few trabeculations. And 64% have some trabeculations, which may be on the medial side, or maybe they may be dense. These trabeculations may be dense and sparse, and based upon the trabeculations and the contents like adipose tissue and connective tissue, the topography of the cavernous sinus would be visible in angiography. So cavernous sinus drains anteriorly into the ophthalmic, can be both superior, inferior, angular, and then facial vein. Then there can be meningeal and osseous drainage by the sphenoparietal sinus. There can be superficial middle sabal vein and uncal vein drainage. Medially, there can be pituitary venous drainage, and through intercavernous sinus there can be opposite side drainage. Then there can be clival drainage also, clival and meningeal drainage. Then this can drain into the pontine vein or superior petrosal sinus as well. So if you see, this is a case where there is no ophthalmic or petrosal drainage, but whole cortical drainage. So why it happens? This cavernous sinus has got uncal vein drainage as well as superficial middle sabal vein drainage, which can lead to cortical reflux. So based upon the location of the drainage, there can be symptoms: ocular, auditory, or both, or related to raised intracranial pressure. So these are the few examples of cases with CCF. Now, next thing is, what do you mean by fistulous communication, location of fistulous communication? The cavernous extent of cavernous sinus is right from the this PLL, the petrolingual ligament, up to the anterior clinoid process. It is not a small paracellular structure, it is a huge structure, and this can, so you may find the communication, ye nahi chal raha, this is not working. This you can find the communication right from the PLL to the interclinoid. So this huge area, you need to see any communication right from the vertical segment of the internal carotid artery, that is the petrous segment, up to the clinoidal segment. So if you see, this is the case where this is the anteromedial aspect of the cavernous sinus which is dilated, and the communication is here. This is so small communication. So you need to identify the communication, and you can close this with the coils. This is another case where this is a huge complex kind of venous drainage, opposite side petrosal, and the communication, however, is only in the cellular part of the internal carotid artery. कौन सा है इसमें? बीच वाला है? हाँ. And this is pre-operative. नहीं चलता भैया. This is pre-operative picture of the patient, and ये भी नहीं चल रहा, माउस भी नहीं चल रहा इसका. And the opposite side is post-operative, immediately after the coiling. This is another case where this is slit kind of communication, and this can be coiled or can be treated with a stent. This is another case where the petrous part of the internal carotid artery, the communication is here, which is closed by the coils. This is another case in the sellar area and entromedial aspect of the sellar area. Now this was a gentleman, 32-year-old. He had the left eye symptoms, left orbital symptoms. However, the DSA showed no left side cavernous sinus filling up. So left side cavernous sinus is aplastic or hypoplastic, and through intercavernous sinus, the opposite side of the cavernous sinus is ballooned up. So this is causing symptoms in the other eye. So there can be symptoms in the other eye also, and this was occluded using the coils in the intercavernous sinus. Another case with the which is occluded with the coil, and here you can see that there is good intercommunication, the communication between the two cavernous sinuses. This is another case where there is communication between the meningohypophyseal artery. This is the meningohypophyseal. So it is not only the internal carotid. You can see the branches arising anterior or either on the anterior aspect or the posterior aspect of the internal carotid artery. This is pre-operative and post-operative. You can see the improvement intraoperatively on table. So we did a study on intrafistulous pressure measurement in traumatic CCF, and if we see this 110 was the pressure in the beginning when you have entered and cannulated the fistula, and this is during the procedure. From more than 100 the pressure drops to almost half, and this shows that if you wait for some time, unlike coiling of aneurysm where you have to compactly coil the aneurysm, here you can wait, and while waiting even your communication can completely occluded. And this is another case where you can, besides coils, you can use onyx, you can use NBCA. This is NBCA. This is supplied by the external by the internal carotid artery again, which was occluded by the NBCA. And this is another case where the supply is from the external carotid artery. This is type D fistula, and this is again also low flow fistulas which can be very well treated by the onyx or the NBCA. The CCF can be fatal as well when there is so big venous reflux because of intracranial hypertension. If they are not treated well, and if the communication is not, this is not disconnected, the venous communication, then they can be fatal. And this you can definitely see the change in the preoperative and postoperative orbital symptoms when the connection is completely occluded. And you can preserve the extraocular movements also even after using the coils. So this is another case of petrous ICA communication, and this communication was not, we were not able to hook the communication with a microcatheter. So we used the covered stent. We used the covered stent, which is Abbott's covered stent. For this, of course, you need the long sheath and the distal access catheter. Long sheath means distal access catheter, which can carry this heavy wall stent. This wall stent is actually labeled, it is used for the peripheral vessels, and this case was done again using the covered stent, and this stent is from Abbott and it costs only 9,000 rupees, just 9,000, and this was covered this, and you can see that this artery was so important. It was feeding all the circulation of the brain, and this is pre-operatively. Here you can see the post-operative, the communication is gone. This is another case where we did the coiling in the first attempt but could not achieve the 100% occlusion. So on follow-up, we did the angio, found this, they were still filling up, and this was again treated by this Abbott's Graft Master. This is pre-operative, and you can see the post-op change. Now, as in type 2, where you have the branches of the carotid artery, where the communication is between the branch of ICA as well as the cavernous sinus. This is another case where this is Vidian artery. This is Vidian artery. So you need to understand the anatomy well when you are performing the DSA. It is not that the communication, but where the communication is, what is the anastomotic patterns which are there. This is Vidian artery which is communicating. This girl, young girl, had external carotid communication also, which was treated by putting the coil. But since this was difficult to cannulate this artery, so we did with the covered stent, and you can see that you are not seeing this artery what you were seeing in this scan, this angio. This is one more patient, 48 years old female. She had this external communication as well as internal communication also, and draining into ophthalmic vein. We couldn't cannulate the communication, so we did the superior ophthalmic cannulation, direct cannulation, where you can see this is the medial aspect of the superior eyelid crease. If you draw a line at superior eyelid crease, and the medial most quadrant, there you find the ophthalmic vein. You're keeping the catheter in the artery, you're taking the shoot till the vein, till the venous face, and that can be an extra additional landmark or help for you to cannulate the superior ophthalmic artery and these superior ophthalmic vein, and these veins can be cannulated directly by the 18 gauge cannulas, and through this you can take the microcatheter. This light shadow you are seeing, this is microcatheter, this is the tip, this dot is the microcatheter tip, and you can coil the communication. This is pre-operative, this is post-operative, immediate post-operative. There is stagnation of the flow is occluding here, and after 2 days we did the angio, repeated the angio. This is pre-operative and this is post-operative, the communication is gone. Similarly, you can make small craniotomies for fistulous communications where they are draining into the cortical veins and you are not able to, do not have access for the cortical veins. So you can make small craniotomies. See, the superficial middle cerebral vein is so tortuous. When you cannulate these veins with a small 18 gauge cannulas, the blood comes out as if it is the arterial blood. And you can go and take the microcatheter through these these small cannula, and you can reach right, you're seeing this black blood, you can reach right up to the venous communication, the communication between artery and vein. This was a young man who had trauma, and he was tried all kind of treatments, the intra-arterial, the petrosal treatment also, through the sinus also, and then finally this was the superficial the middle cerebral vein was still filling up. So these are the CCFs which are the most dangerous. They cause intracranial hypertension, they can bleed, and they can be disastrous also. So this is pre-operative and this is post-operative. You can see that this vein is gone there, and this steel which was visible here, that is the flow is coming back. So to conclude, understanding the anatomy of cavernous sinus and its venous drainage is very essential to understand where the CCF is, what is the communication, what route you want to take, which way, venous or arterial. If venous, what vein you want to take, and you can get good results by using devices which are economical. If you want to use stent for the vertical segment, for the lesser vertical segment, you can use covered stent. There's no need to compactly coil the sinuses or the communication. With time, the flow diverts itself, and of course, you can add Onyx and NBCA if you feel that you are using lots of coils to reduce the cost. And in endovascular, as Dr. Karapurkar also said, that the whole team has to be in action. Of course, your colleague, you are not only the one person who is doing the show in endovascular. It's a teamwork which is very important. And thank you for patient listening. I invite you all for the Neurovascon 2023, which is going to happen in Delhi only next year, September. Thank you for patient listening.
Thank you, ma'am. We are amazed to see the vast experience you have with carotid cavernous fistula. Now the house is open for question.
Sorry?
Have you had any CCF secondary to trigeminal thermocoagulation, radiofrequency injections?
No, never heard of.
May I answer that question?
Yeah, Dr. Karapurkar.
Sorry, I'm on the yeah. So I had seen a couple of patients long ago when they used to do this for vasomotor rhinitis. They used to burn the median nerve, and the ENT surgeons. And I had seen a couple of patients. So there it is usually a direct type of high flow carotid cavernous fistula, and most of the time you can treat it with a balloon, with a detachable balloon. Or today we don't use detachable balloon so much, we can do it with a coil, either by the arterial route or by the venous route, as Anita showed.
Okay, thank you, sir.
We had one patient who had a persistent trigeminal artery, and there was an aneurysm on the persistent trigeminal artery which had ruptured into the cavernous sinus, resulting in a CCS. So there again we had to treat the aneurysm. This again was many years ago. Yeah.
Thank you, ma'am. If there is no question, we want to proceed to the next speaker. Our next speaker is online. He is Dr. Naoto Kimura, and he will talk on this topic.
Okay, thank you.
It is my great honor to have a presentation in this ISME meeting. Unfortunately, I have to apologize that from my hospital's regulation, I could not attend the meeting today at India. But someday I would like to come back to India. Today's my topic is technical tips for the complicated thrombectomy for the acute stroke. Today's topics. The first is the basic, that thrombectomy is a mandatory treatment, and the tandem lesion and the posterior circulation. First, almost is a meta-analysis of the thrombectomy. Endovascular therapy increases MRS 0 to 1, 14%, MRS 0 to 2, 20%, comparing to the standard therapy. Overall treatment effect number need to treat is only 2.6. This means if we treat 3 patients, more than 1 patient get better. But we have to figure about the reperfusion time and the reperfusion rate. If the reperfusion time is slow or the reperfusion rate is low, the patient outcome will be worse. So we have to select faster and treat faster. And this is diffuse 3, the thrombectomy for the stroke at 6 to 16 hours with selecting by perfusion imaging. If we select a patient from the 6, even it passed more than 6 hours, the patient get better comparing to the medical therapy. And this is Dawn trial. This is for the 6 to 24 hours for stroke with mismatch. This also shows that the patient will get better if we treat by the perfusion image. From these papers, the AHA guideline shows that within 6 to 16 hours as last known is evidence level A, and from 6 to 20 hours, this is B recommended. In Japan's guideline, it is also same. From 0 to 6 hours, if we don't have the large ischemic core, we have to treat the patient, even if the aspects NIHS is around 6. And also from 6 to 16 hours, we can select the patient by the MRI. If the MRI aspect is more than 7, then it is great evidence to do the treatment. This is the latest paper from Japan, the endovascular therapy for the acute stroke with large ischemic region. This we randomly treated aspects to 3 to 5. This means that we already have the large ischemic core. From this paper, the modified ranking scale 0 to 3, there was a significant difference between the medical group and the endovascular therapy group. So even if we have the large ischemic core, aspects 3 to 5, the patient will become better. But we have to notice that if we do the endovascular therapy with the large ischemic core, the internal hemorrhage will increase. Now I move to the aspiration catheter adapt technique. Comparing aspiration first versus stent retriever first, ASTRA trial shows that the TK2B3, the recognition rate, is almost same as a stent. And the puncture to recognition time is 31 minutes comparing to 44 minutes. This is a little bit faster comparing to the stent. And this is another paper that for the COMPASS trial, the ADAPT technique, the good recognition is up to 91%. But the MRS 0 to 2 was significant difference comparing the ADAPT and the stent. So this two papers shows that the ADAPT technique using the suction catheter compared to the stent is not infering or functional outcome. Anyway, we have to treat the patient faster. So for the TPA, we consider from door to the TPA 30 minutes and the door to the puncture 60 minutes. So this is a flowchart of the systemic of acute stroke patient. If the patient arrives, we have to consider the TPA first, and if we have the indication for the TPA, we do the TPA injection and we go to the CTA or the MRI. And if we show the major vessel occlusion, we go to the thrombectomy. And even we don't have the indication to TPA, but the patient within 24 hours, we will take the CTA or the MRI, and if there's a large vessel occlusion, we go to the thrombectomy. How about combined technique of the stent and the suction catheter? There is a randomized controlled trial comparing the combined technique and the stent retriever. This is from France, and there's open label and blind endpoint trial. The effective recognition rate, the TK2C and 3, was no significant difference between the combined technique and the stent retriever. And 3 months and 20 months MRS was no significant difference between two groups. But if we see the result, assigned the initial intersection alone is TK2B3, C2C3 was combined better. And the rescue treatment is lower in the combined group. So this means the combined therapy may be better. And the conclusion of this study, the parenchymal hematoma was also low, so the trial maybe have the underpower to detect smaller difference between two groups. So if we have more patients, we think that the combined technique will be a little bit better. So from these papers, the stent retriever, we have that high evidence level, and the ADAPT technique also high evidence level, but combined low. And procedure, the ADAPT technique is very easy. It's a little bit faster than comparing the stent and combined. But the recognition, the combined technique is a little bit high, and the cost is also high. So in our hospital, we do the combined technique first because of the high reconnaissance rate and a low complication. So the first pass we do the combine with the anterior circulation using the 9 French balloon guiding catheter. With the stent we choose by each vessel. The ICA we use 5 to 6 millimeter stent and M1 proximal 4 to 5 stent, and M1 distal to the MIBO we do the smaller stent. And for the posterior circulation we cannot protect both VAs, so we use a French guiding catheter using the adapt technique. I'll show you one patient. I'll show you one case. This is 84 years old female. This is preoperative CT. The CT shows that aspect ratio 7. We have a small amount of the infarction here. And the preoperative CT shows the right ICA occlusion. So we move to the angio suite, and when we do the ICA injection, we saw the M1 proximal occlusion here. So we navigate the microcatheter and deploy the stent with using the suction catheter. And we pull the stent and aspirin catheter together, then we have the good recanalization rate. So this is our data from the 2019 to 2020. Our TQ2B3 is around 88%. This is real world data. Now I move to the difficult case. The case when we face the tunnel, what should we do? Is it better to use stent or no stent? This paper shows that even if you use the stent or we don't use the stent, the outcome is almost same. And this paper, is it better to do that antegrade or retrograde? This means that we do the thrombectomy first or the stent deployment first. This shows that the TQ2BC was 83%. So even we have the tandem lesion, we can get a good reconnaissance rate, and there's no different outcome between antegrade and retrograde. So this means it is better to do it, but we don't have to think about the procedure. So I show you my case. This is right ICA occlusion. This is preoperative CC angio. This shows that there is no collateral flow from the ACOM, and we see that right ICA occlusion. And this is neck ICA. We can't see the ICA, and we see that there are tiny, very severe stenosis here. So we thought that we cannot put the suction catheter at this tiny stenosis, so we try to do the stent first. So we deploy the stent. After that, we make the route to the MC occlusion, and after that, we deploy the stent, and we do the stent retriever with the suction catheter. This is very important because we already put the stent at the neck. So if we pull the stent retriever to the stent, this will stuck. So we deploy the stent with the suction catheter, and we got a good recanalization like this. So this is a preoperative, and this is a postoperative CCAG. Now next, MC occlusion. There is no evidence for the MCA atherosclerosis. This is a preoperative CT arrival at our hospital with the right hem paresis. We have the very old infarction, but this is not this time. If we do the MRI, we see the M1 stenosis here, and we see some infarction at the left frontal lobe. So we move to the angio suite, and we see the M1 occlusion here. So we are going to do the thrombectomy. First, we navigate the micro guide wire through the stenotic part, and when we reach to the distal part, we do the suction.
चल नहीं रहा है.
ठीक है, चल रहा है.
After the aspiration catheter, we saw the very severe stenosis at the M1 proximal, like this. So we go to the PTA with a 3 millimeter balloon, like this. And we get the second session, and we did the third session. After that, we got a good recanalization and a good dilatation of the left M1 proximal. And this is a cone beam CT, shows that we have the good good dilatation here. And this is a postoperative CT. We have some SAH, but the patient have no worsening of the MRS. And this is a postoperative MRI. There's no increasing amount of the infection. Next, I move to the basilar occlusion. This is a patient, this is 73-year-old male. The patient just come to the hospital with sudden disorientation, vertigo, and at this time the NIHSS was only 0. So we just get the patient in admission. After a while, after CT, the neurology worsened to the tetraparesis and NIH38, and we saw the hypertension sign at the basilar. And this is a CT angio. We saw the basilar occlusion with the left VA severe stenosis. So we did the TPA injection, we moved the DSA. So this is a left subclavian angiography. This shows that the left VA, you have a severe stenosis and a basilar occlusion. So at this time, we first do the PTA to the VA proximal. After that, we do the adapt technique and get the recanalization at the basilar. But after a while, the VA stenosis got worsened once more. So we tried to do the PTA several times. And also the left VA was occluded by observation, and aspiration and clopidogrel was given at this time. So we don't have the right VA because the right VA was a pike at end, so we did the PTA to the VA. And we got a very high amount of the debris here. But unfortunately, the patient became worse. There's some reports of the endovascular treatment for the posterior circulation tandem lesion area. We saw the 36 cases, but there was no evidence of the procedure, antegrade or retrograde. There are several approaches for the posterior circulation tandem lesion, the clean load pathway and the dirty road pathway. The clean road path approach is the thrombectomy from the contralateral side, VA, and the dirty road pathway is we have to go with the approach from the stenotic side. This case that we have to choose the dirty road pathway because there was no contralateral VA because of the pike end. And we did the thrombectomy after PTA. And the retrograde approach will be the better because intracranial recanalization can be a priority. Now, show you another. This is the last case of the direct puncture. This is 79 years old female. The NIHS was 32. She has a left M1 occlusion. But when we did the CT angio, we saw the aortic dissection stand 48 with a CC dissection. This is a ultrasound shows that we have some flap at the proximal of the CCA, but the distal part was okay. So we did the direct puncture using the ultrasound, under ultrasound. After that, we got the reconnaissance. So even with the aortic dissection, when we use the puncture, we can do the thrombectomy. So this is my conclusion. Thrombectomy is a mandatory treatment. Therapeutic time and aspects are changing these days, so we have to see the papers a lot. And the stent and the stent and suction catheter each have a high evidence, and no evidence in the patient outcome combined technique. But we believe that this have the high recognition rate. The strategy for the tandem lesion is not clear, but recurrence rate is not low, so we have to do it.
Thank you. It is a very nice talk on stroke management with endovascular therapy. Is there any question? Is he online?
Yes.
We are running behind time, so if there is no question, we can proceed to our next talk.
Yeah, thank you, Dr. Natao. Very nice talk. If there is no questions and comments, we can move on to the next talk. The next speaker is Dr. Shweta Kedia from AIMS Delhi, additional professor in neurosurgery. Should be talking on gamma knife for complex AVMs.
So, a very good afternoon to all of you. I'm going to discuss the technical nuances of radiosurgery in giant AVMs. I know this raised a big question mark as to why are we treating giant AVMs, but let me just take you through what our experience. Now, we all understand that the current role of gamma knife in AVM is mostly for less than 12 cc in volume AVMs or less than 3 centimeter, that would be centimeter in max dia. And also for AVMs which are located in the deep or the eloquent region. And we all know the standard favorable outcome commented in literature with standalone gamma knife is 61%, although our experience suggests around 75 to 80% obliteration rate. The annual post radiosurgery hemorrhage rate is around 1.4%, so it is not the same as the as in the natural history. It definitely is less, even in the latency period. Symptomatic and permanent radiation induced change occurs in, so symptomatic would be 9% and permanent is seen only in 3%. Yet we have been practicing and giving gamma knife to the patients with the large AVM. Why is the slide not coming? So, for example, this is a case of 11 years old child with history of visual field defects and a headache. Was having a volume nidus size of 13.38 with the radiosurgery based AVM score, that's the FP score of 1.558, which means a low probability of obliteration. And by SM grading, if you go by that, it was grade 5, was subjected to primary gamma knife. So this is a study which we did on, we stopped counting after that. So total patient of 108 were included in this study, although we've done many more than this over last 5. This is a study of covering last 5 years data. And there is male predominance with a median age of 24 years, and only 8 of them had presented with evident bleed, although MRI of most of these patients do show microhemorrhages. The mean nidus volume was 13.8 cc's and mean PF score of 1.73. So we're talking about giant AVMs, SM grade round 3, 4, and 5. So there are a lot of fallacies in SM grading also. We would not be discussing that, but yeah, so demography, as I said, the mean age was around 24 with the male predominance, and the presentation most of the time is chronic headache. So the reason why we are actually dealing with these giant AVMs is because they come to us with incapacitating headache or neurological deficits, which may or may not improve post gamma knife, but definitely needs a treatment. So, so these patients were taken up. The I don't know how many of you are actually doing gamma knife, or you might be in the line of getting one gamma knife icon machine to your center. So just to understand that the nidus is treated at the margin, we always talk about the margin of the nidus, the dose that it is going to receive and the center of the nidus is definitely going to receive more than what it is getting at the margin, so it's almost double. So 18 to 25 grays at the margin, 50% isodose line. So at the center it would double. The 50 gray isodose would fall in the center. Targeting coverage of 100%, but yes, 95% is supposed to be a good plan. And only 18 patients of amongst these 108 were fractionated. 16 of them needed repeat gamma knife radiosurgery. So the the technicalities in treating these giant aviums which we use, and you can see the differences. So this is a patient of 34 years female, had presented with left lower limb weakness, present around near the motor strip area, with a volume of 12.68 cc's, was treated with single fraction gamma knife. But what we tried to do over here was, and we routinely do, is spare the deep vein in planning the nidus. So when we mark the nidus, we try to avoid. So we have observed that if we include the deep vein and treat it with the same dose, the radiation change that's what we're afraid of when we're talking about gamma knife in large aviums, and therefore the deep vein sparing is usually employed in our institute. And you can see the follow-up scan after 5 years, which is excellent, I would say, because it has minimal radiation change with no significant edema. We may also, now you see the deep vein sitting here and the nidus around it. We may also consider it not as a single volume but a 2 volume nidus. So treat it as 2 separate volumes and dose it accordingly, and then you get a very good result, and try and achieve a compass. What we generally follow, however, is the volume staged gamma knife radiosurgery. So this is temporal staging. Again, here the nidus is divided into 2 components, A and B, but we are not treating both the volumes at the same go, but we would get in the patient after 3 to 6 months and retreat the remaining nidus with the calculated dose. So this total volume of the nidus was 15 cc's, yet the 13 cc was treated, and then the remaining 2 cc was treated at the 5 months interval. At the eloquent cortex, again, we try to modify the dosing. So you see what we're playing it with is with the total amount of dose that I'm going to give to the nidus. So this is a 26 years female presented with seizures with a total volume of 14, again being treated with single session, but over here of course the dosing is reduced. So we prefer a little lower marginal dose, and in the follow-up, if we find a residual nidus, we would like to get in the patient back again and do a redo gamma knife radiosurgery. So that is how we deal with the eloquent cortex. And you see this patient did excellent with 18 gray marginal dose also. So the dose being delivered at the margin of the nidus was 18 gray, and very good result, I would say. And this patient walks with a limp but has no significant morbidity, I would say. Another strategy that is commonly being used elsewhere and at our place also is use embolization to assist in obliterating partially the nidus and reduce the volume of the nidus. So this was like 22 years male embolized in 2004 and so this was not a pre-planned embolization followed by gamma knife radiosurgery, but yes, we are now going in for a pre-planned embolization, tackle the intranidal aneurysms which increases the risk of rebleed during the latency period, or tackle any high flow area with a volume of 15.23 cc and again treated with a single session gamma knife done. And this is the interval scan at 2 years. You will see significant reduction in the nidus. We generally wait for 4 to 5 years to see a complete obliteration on the MRI. If there's a good obliteration observed in MRI, we may skip doing a follow-up DSA altogether. So overall obliteration rate was not bad. It's 66%. As per the literature, just like I told you, it was 61. And rebleed was seen in 4%, probably because of the residual nidus that was there. Yet we did see post-radiation edema in 18%, delayed cyst formation, and 16 patients needed a redo gamma knife surgery. So this is one of the examples, 16 years female patient who was treated by gamma knife radiosurgery, 3 years follow-up. This was just for the study purpose that we did an early angio because the MR was showing good result. This is located very close to the brainstem. The dose that we deliver is a titrated dose, but you can see how nicely the nidus is gone and at the near the brainstem. So 18 grays dose was given to this patient with a good obliteration that was achieved at the end of 3 years follow-up for this patient. Now this is another patient with left-sided thalamic AVM, the nidus volume of 6.43. So you see the nidus. Now this I have kept just to show to you that the residual nidus is not related to the size of the nidus, but depends on how well you delineate your nidus. So a primary gamma knife was given, PF score of 1.42, SM grade 4 because of the deep veins and the eloquent location. This patient had an in-field residue. So when we talk about gamma knife and the AVM, there are two components. There's in-field residue and the out-of-field residue. As you can understand by the terminology, in-field residue would be the gamma knife nidus, which has already been treated by the gamma knife, and within the margin, within the marked nidus, you find the residue. However, the outfield nidus that we see usually because we use the deep vein sparing planning method, there would be some part of the nidus that is being left behind because we're trying to spare the deep vein, and that we call as out-of-field residue. So you do get in-field residue and out-of-field residue irrespective of the size of the nidus. Now this is another example of an outfield residue where the patient was treated by the repeat gamma knife. We do see edema in the form of radiation-induced change. So it can be radiation necrosis alone, radiation necrosis with edema, or the cyst formation. Some of these edemas, they are managed with steroids, controlled very well, and you just have to start the patient on tapering dose of. Sometimes we give prophylactic steroid dose to a giant AVM if we are assuming that there is just a single vein draining the nidus, and we expand located in the deep area and the eloquent area, we would give the steroid prophylactically. Or there are patients where you would get to see significant. So this is the out-of-field nidus that is there. So this patient again was treated with a repeat radiosurgery, but you see the repeat radiosurgery again is not responsible for radiation-induced change, and the patient do well. So the radiation necrosis alone or radiation necrosis with edema may follow the gamma knife radiosurgery. So this is another patient where significant mass effect is observed. At 1 year follow-up, the patient usually comes back with headache. So these patients, when we see are steroid resistant, we have also given bevacizumab to these patients, and some of them have responded well. So they get either single shot bevacizumab or 2 shot bevacizumab, and they do well. So it is also a doable thing, and the radiation changes almost disappears, which is routinely being followed in the recurrent GBMs when we're giving radiation-induced changes. We're using bevacizumab. So this was another case of 8 years male patient with ictus and with history of seizures, volume of 17.98 cc's, showing significant radiation necrosis with edema. There are few patients who may present with cyst. So now if you can see, as your volume increases, this volume is 22 cc. So 26 male with history of headache and seizure with volume of 20 cc. So what we have observed is the volume of the nidus around 16, 17 cc still show good results. But as you cross the 20 cc mark, they start showing more of radiation changes and unmanageable cyst. So this patient had to be taken up. Decompressive was required. The patient also received bevacizumab, didn't do well. We actually lost this patient to radiation changes. So that would put a limit to the AVMs that you can treat with gamma knife, could be just left alone, although their headache is anyways very incapacitating. So we have a paper published from the institute where we have shown that large volume AVMs can be managed by gamma knife radiosurgery with acceptable risks. It's mostly for grade 3 and grade 4 AVMs. Grade 5, we definitely go in for more conservative approach unless it is unless there is a way we can, embolize and cut short the nidus volume. Single fraction gamma knife radiosurgery should be considered for moderate sized AVMs located away from the critical structure. Large volume, the best way to go about is volume stage. Now we have the icon where we can use the mask based system, so we can fractionate the dosing schedule very easily. We can do it in a fractionated fashion over 5 days period, and I think that is a good alternative to volume staged gamma knife radiosurgery. A very beautiful paper published by Yoko Kato and team in 2022, Expert Consensus on the Management of Brain AVMs, covers about all small and large AVMs, talks about Aruba also. But for large AVMs, the committee had made following recommendations: grade 3 and 4 to be treated with multimodal approach. Grade 4 AVMs, what they believe in the posterior fossa and the occipital, should be managed with surgery. We have both. We have managed with surgery also occipital AVMs. We have given gamma knife also. We have surgery is the best modality for AVM. There is no questioning that. If surgery is not found suitable, the patient does well with gamma knife also. Grade 5 AVMs to be treated with conservatively. So to conclude, a holistic approach should be adopted for gamma knife in AVM. Our target is to achieve complete occlusion, and for that, if we need to use embolization, and there are people who would recommend gamma knife followed by surgery also. So there are papers who are talking about pre-surgery gamma knife and then go ahead and operate. So you reduce the nidus, decrease the size of the nidus. Conservative management is an option for giant AVMs. There is nothing wrong if you want us to. And there are patients who have dysmorphic vascular malformations who are present along with the AVM nidus. So any diffuse nidus, we would want not to intervene. Giant AVMs and redo gamma knife needs close evaluation. However, none of the size is not shown to have an impact on the obliteration rate or the radiation induced changes, as I showed in some of the examples. So yes, we're still working on the giant AVMs and trying to find out a new classification and to find out which patient would benefit from the gamma knife radiosurgery the most. Thank you.
Yeah, thank you, Shweta. Very nice talk and very good results you have shown. And any comments or questions? You are fortunate to have a good machine also.
Yeah.
But I want to ask one thing. Initially, people used to say that embolization should not be done if you are subjecting the patient.
Yes, they're controversial. So what they say is delineating the target after embolization becomes difficult because it leaves a cast. And we have, so the results in the literature has shown that there is a lot of residual nidus if we are treating after gamma knife post embolization, although it didn't show significant deterrent factor in our study. So embolization actually did not hamper the obliteration rate in our study. The residual nidus was mostly seen in patients where we have more actively gone for deep vein sparing system. So delineation of the nidus because of you want to leave the critical structures out are more responsible for residual nidus. So embolization has not caused any hindrance as such.
Okay, one more thing. If there is intranidal aneurysm which is not bled, will you do the gamma knife?
We have given gamma knife to patients who have been detected to have intranidal aneurysm and perinidal aneurysm on the DSA because if they were found to have AVM on the MRI, and we've gone ahead with primary gamma knife for these patients.
Okay.
Thank you.
Thank you, ma'am. With this, we conclude this session.